working here. All right. So you guys should be able to see my slides. All right. So I'm going on the assumption that not everyone's been able to watch all of the webinars that have been happening. There's been a lot of them. I know some of you have, so I'm sorry for boring you, but I just want to make sure everyone's kind of on the same level and has the same information. All right. So just real quickly, monkeypox was first identified in a monkey in a research lab. That's why it's called monkeypox, even though it's not endemic. You know, it's not, the primary host is not monkeys. So it was back in the 50s. In the 70s, they first found the first case in humans in the Dominican Republic of the Congo. It's endemic in Central and West African countries, which are kind of represented here in these colored countries of Africa. Most cases are sporadic, and there's localized outbreaks in Africa. It can occur in many different animals, but the definitive reservoir that it mainly stays in is not known. Animal to human transmission is usually through bites or scratches, or in the handling of animal products, so bush meat, skins, leathers, things like that. Human to human transmission is thought to occur through direct skin to skin contact with the lesions, indirect contact with contaminated fomites like bedding and clothing, or really close proximity and really extended contact with exchange of the respiratory secretions. So the monkeypox is part of the genus Orthopoxviridae, so it's an orthopox virus. I'm sure you've heard that already. There are two distinct clades of monkeypox. There's a Central African clade and a West African clade. West African clade is more limited illness, more mild illness, and has a lower fatality rate. And the fatality rates are all based on African data, and you know, some of it has to do with just more limited access to care, and most of their cases have been in younger children and younger individuals. So our fatality rates have been really low. So again, some of this data is difficult to transpose to what we're seeing now. So the West African clade is what's causing this global outbreak right now. The Central African clade, sometimes called the Congo Basin clade, seems to be more transmissible, have a more severe illness and a higher case fatality rate of around 10%. There's many other pox viruses that cause human illness. Just a few of them are smallpox, cowpox, molluscum contagiosum, which I think most of us are familiar with, and the ORF virus, which I really know nothing about, but it's been brought up a few times. Illness with one orthopox virus can cause cross protection, which is why smallpox vaccination can help protect you against monkeypox illness. And really, that's one of the thoughts as to why we're having so much problem right now, is that our smallpox vaccination ended in 72, 73, and internationally it ended about around 78. So the majority of people that are 50 or 40 or younger, depending on what country you live in, is not immune to smallpox. I'm not going to go through this whole thing, but this is just prior to this outbreak where monkeypox has been seen. You can see the DRC has had lots of monkeypox over the years. Nigeria really had none until 2017. It started to have sporadic outbreaks. The United States had an outbreak in 2003, I think 2003, due to pet prairie dogs. The orange ones are the West African clade, the pinkish ones are the Central African clade, and then Cameroon's the only place that's had both. So again, there's been a 20-fold increase since '86, and I'm not going to read through all of this, but it's thought it's been increasing because there's been more poverty, more people going to urban areas, more interaction with rodents, which are a big carrier, more use of bush meat, better diagnosis and contact tracing in Africa, and more travel, just more people interacting with each other. But more recently, there have been more international cases than usual. So the UK had cases in 2018, 19, 21, and 22. Israel had one in 2018. Singapore had one in 2019. And we had two cases last year. None of these seem related to what is going on now, but all of these were travel related with links to Nigeria. So the typical traditional clinical presentation is usually in endemic regions of Africa, a young male, not immune to smallpox. Usually there's a prodrome with fever, headache, chills, malaise, lymphadenopathy, and then a characteristic rash. Usually starts in the mouth, then face and extremities, including the palms and sole. The rash comes on all at the same time with the same phases. Again, this is traditionally, you'll have a macule, then a papule, then a vesicle, then a pustule, and then a scab. They're usually painful, then they can become itchy as they heal. And you can have a few to over 100, and they can last up to 4 weeks. Now, with this current outbreak, early in May, there was a case noted due to travel in the UK, and then it spread to a few household contacts. Another 2 cases, another case was found shortly after that was unrelated. And then within 2 weeks, the UK had found 15 more cases. By the 24th of May, at least 21 other countries had found over 270 cases. Almost all the individuals that they knew the gender on were male. Only one was female. Most were young adults, so they were not immune to smallpox. Most identified as gay, bisexual, or MSM. And so it's thought the transmission is occurring through very intimate skin-to-skin contact. So just to give you an idea, the red line is the number of countries over a month, and then the blue bars are the number of cases over a month. So with this many occurring in so many different countries, it's thought that there were multiple different cases that were exported into different countries and unrecognized local spread that just was not identified for some time until people started to know to look for it. This is as of the 8th. There are over 8,200 confirmed cases. So there's probably a lot more probable cases in 57 different countries. The US is number 4 right now. I meant to put this here. In the US, nearly all of our states have cases. We're at 767. This is confirmed and probable. Really, if you have an orthopox positive case, it's monkeypox because there's really no other circulating orthopox viruses right now. Michigan has 3, and I think there are others being investigated. The CDC gave a really good webinar, and they really are struggling to get good, complete demographic data. But at that time, they had complete information on 305 cases. And from what they had in data, 271 of those individuals were male sex at birth. And what they knew, 76, they didn't know about sexual preference, but they knew on 195, and 193 of those individuals did have male-to-male sexual contact. So again, the current outbreak is the largest ever in history, but it's not really suspected we're going to have a huge global pandemic like we did with COVID because it's not a novel virus, and we already have vaccines and therapeutics that do work against the virus as far as we know. There is concern, though, that if this outbreak continues, that it could become established in other non-endemic animals. So like it could get established in our rodent population, our squirrels, things like that. And if that happens, it could become endemic in other non-African countries, and then that would be a problem. The clinical presentation for this outbreak is not that typical presentation, which has been confusing for a lot of people. So the rash is still present, but it may not be all over the body. It may just be in the genital area, the anal area, perianal, sometimes in the rectum, in the anus itself. The lesions are often in different stages. They said in the CDC calls that even lesions right next to each other might be in different stages, which is very atypical for this disease. Some of the presenting complaints may be just anorectal pain, tenesmus, which is that feeling like you have to have a bowel movement, but you can't, so it's from that swelling. The physical exam initially may not really show any lesions, just that proctitis symptom, that pain symptom. They're finding patients really don't have any prodromal symptoms, or those symptoms may happen after, like postdromal, so after the rash occurs, may co-occur with STIs, so it makes it even more confusing. People often confuse it with chickenpox or molluscum contagiosum, herpes because of the pain, syphilis, other rash diseases. So it's important to keep it in your differential, but it's also important to keep the more common things like syphilis or herpes in your list as well, so that you don't keep blinders on and miss the more common things. So I'm going to show you some images of the rash, and then there was a good case report the CDC showed. Of course, there's going to be some genital pictures and rash pictures, so just, I know we probably don't have any queasy people on the line, but just in case. So this is from a report from Italy. So this is the days from onset. The onset was really those prodromal symptoms. So the rash really started on day 5. So there were anal lesions, and then genital, just a small rash lesion here. And then the lesion here was somewhere on the body. But you can just kind of see the development of the rash. That was not quite as profound, but I wanted to include some differences. This next one is a case report from the CDC. So this was a Hispanic male that the clinic doing this presentation had as a patient in their PrEP clinic. So he reported that he had these little bumps. You can just barely see them, little white bumps here. And this was on June 2nd. He had had sex with 3 men at a sex party on May 29th. He didn't know anything about their travel history. He himself hadn't had any travel history, and he had no fever, swollen glands, or fatigue. So that was the second, and then actually, yeah. So then the next day, on the 3rd, the bumps have gotten a bit bigger. They saw him in the clinic. They noted that he had the small bumps, that they were firm, they couldn't unroof them, and they were painful. So they did his routine testing for PrEP. They also did an RPR test. They did a herpes culture. They figured it was herpes, started treatment. They did talk about monkeypox, but did not test for it because it was so soon after the sexual exposure. He had no prodrome or anything like that. So they did not do testing. The next, let's see, that was day 2. So 2 days later, the lesions had progressed to look like this. So then the following day, they got back labs. The only thing positive was urine was positive for chlamydia. The HSV culture was negative. So the lesions had continued to increase in size, were getting much more painful. Foreskin was getting swollen and painful, was getting lesions otherwhere on his body. He was starting to get fever and fatigue and decreased appetite. So that was after the rash had started. He found out that one of the partners from that sex party lived in Toronto, was symptomatic, and had received a diagnosis of monkeypox. So then the next day, on day 6, they had him come back into the clinic, reported that he'd had 10 sexual partners in the last 90 days, 40 in the past year, had used substances with sexual activity, sex with anonymous and pseudo-anonymous parties. And they explained during the reason they were giving this is that they have found this with many of the cases is just really high risk exposures seem to be more common. That was the main reason they were sharing this. I've just kind of copied and pasted it into this, and did have prior history of STDs. So when they saw him on the 6th, there was an oral lesion. You can see back here it's on the right side of the patient, and it was painful when they swabbed it. And then there was another lesion on the chin that did have that umbilicated look and a bit of erythema around the base. The penis was the foreskin was much more edematous. He could not retract his foreskin anymore. It was very painful. They did swab 3 different lesions. They all did test positive for ovipox virus. They got him on doxycycline for the chlamydia. And then on the 8th day, he called in saying he was no longer able to urinate because he was in so much pain and had so much swelling. So they arranged him to go to the ER, and he was given pain medications and was then able to urinate. So I just thought that was a good example of what kind of cases are being seen. They talk a lot about people needing pain management, and you can kind of see why. So the lessons learned were just, the rash kind of began at the sites of exposure. The prodromal symptoms started after the lesions. There was no lymphadenopathy at all. There was co-infection with an STI, and the sexual exposure was only 1 day before his symptoms began. So, this usually has a long incubation period, but again, the rules are kind of non-existent for this right now. We just have to really think about it. So real quickly for testing, Marty at the lab has gone over this. You can get testing done at the Bureau of Labs. This goes over what you need to do. I'm not going to read through all of it. Just know it's here if you need it. It talks about how to do the sampling, how to send it in. Just know too that testing will also be available, and this is for orthopox virus testing, at 5 commercial labs soon. It is already available at LabCorp right now. So that'll come back as orthopox virus positive. That means you have a probable case, but you need to take action right then, because again, if you have a positive orthopox virus, there really is not many other things that it is based on the clinical history. They should be sending, even these commercial labs should all be sending it to the CDC for classification and confirming the diagnosis. But again, based on the clinical history and that orthopox virus test, you should be taking action. This is the case definition. Just refer to that if you have cases. Again, it's basically defined here. It's very long, so I will not read through it, but refer to it as you need to. So what should happen is, if you have clinicians that are concerned about orthopox, what might happen now is they may just simply order it through a lab, and you're going to find out about it on the back end, which is unfortunate. But what should be happening is clinicians should be consulting with us or with MDHHS when they do suspect a case. If we get notified, we should notify our regional EPI or the emerging diseases unit right away. Please notify me, of course, right away, and you can notify Norm as well. You would enter cases into NDSS under the unusual outbreak or occurrence and use Monkeypox 2022 in the outbreak name. There is a short form questionnaire that is available. If it's not been sent to you, you can get it from me or from any of your supervisors or coordinators, and fill that out and then attach it to the notes section. Again, as soon as you have a probable monkeypox case, you want to start action. Your cases are infectious from the time their symptoms started, so those prodromal symptoms, until the lesions scab. The scabs fall off and a new layer of healthy skin is formed. So not like chickenpox. This has to actually go through all those phases, and it can take up to 4 weeks. So that can be challenging for people. They need to stay isolated during that whole time. They can stay isolated at home. There can be some concern with pets. It's mainly if they have pet rodents, but there is information on what they should do with their pets on the CDC website. I know that's what everyone worries about the most is their pets. And there is information there for veterinarians if there are concerns about sick animals. So I put this here just to make a point. Everything you'll read still says after a diagnosis of monkeypox, after a confirmed case of monkeypox. Again, it should say, and I confirmed this with the state on the call on Friday, it really is after a diagnosis of a confirmed or probable case of monkeypox or a diagnosis of orthopox. So I know it's confusing, the verbiage, but really as soon as you have a diagnosis of orthopox or monkeypox, you want to start contact tracing. Contact should be monitored for 21 days after their last date of contact. The incubation period can be up to 21 days, but it averages 12. Again, this outbreak is weird, so you just have to go with the flow. all of this information is in the monitoring protocol on the CD website, and you would keep track of them in the OMS program under Monkeypox 2022 Michigan Outbreak ID. This is on the CD website. I just kind of put it into a table form. You want to determine the risk category of your contacts. So your high risk exposure categories are those that had unprotected contact between skin or mucous membranes, or any body fluids. So people that had sex, people that cuddled skin to skin, people that touched the rash without gloves on, people that got sneezed in the face, you know, those kinds of things, or they touched contaminated materials. So people that changed bedding, washed clothes without protective PPE on. Anyone that was in a patient's room or within 6 feet of the patient during any procedures that created an aerosol, or shaking out of soiled linens without appropriate respirator and eye protection, or per our discretion, basically. Those are the high-risk individuals where we need to consider, where it's recommended they get post-exposure prophylaxis, which I'll talk about here in a second, and that we do need to monitor. Being with someone 6 feet apart for 3 hours or more unmasked, contacts, like basically less intense contacts, do need to be monitored, but don't need post-exposure prophylaxis. And again, just entering a patient room without prolonged exposure should be monitored, but don't need post-exposure prophylaxis. So post-exposure prophylaxis and pre-exposure prophylaxis occurs using smallpox vaccine. There is no vaccine just for monkeypox. You'll see cited that smallpox vaccine is at least 85% effective preventing monkeypox. This is really based on a study from the DRC in the late 80s, which showed that household members that did not get a smallpox vaccine back, in the 70s when it was available, got infected at a rate of a little over 9%, compared to a little over 1% for those who were vaccinated. So it's not really based on any more current data. It's just based on that observation. So just so you kind of understand where that number is coming from. Experts believe that giving vaccination after monkeypox exposure may help prevent the disease and make it less severe, but just so you're aware, there really is no data to support that claim. This is really learning as we go right now, because this has never happened. We've never really used the vaccine like this. Both the vaccines have been studied as post-exposure prophylaxis in animal models and have provided some degree of protection. So it's one of those, it shouldn't hurt, but it might help type of situations for the most part. So there's two vaccines. One is the ACAM 2000. This is the old school smallpox vaccine that was used back in the day, that gave everybody the scar on their arm. It is replication competent. It can cause a lot of really significant serious side effects. We will not be using this. We can get it, we can use it. I don't think really well, the CDC said nobody is using it right now. I do not plan on using it. You have to be specially trained to use it. Jynneos is the vaccine that is being used right now. It was approved for both monkeypox and smallpox in 2019. It does not replicate. It is a live virus, but it's not replicating. So it does not cause live virus in vaccinated individuals. It can be used in immunocompromised individuals, pregnant women, breastfeeding women. The immune response may not be as robust, but it is much, much safer to use. So you can just see the contraindications with ACAM 2000 are very lengthy. For Jynneos, the only contraindication are allergies to components of the vaccine. So for post-exposure prophylaxis, you want to give it as soon as possible. The ideal is to give it within 4 days of exposure, but the CDC says if you give it within 14 days, it may reduce symptoms of the disease. but you probably are not preventing disease. Again, this is all kind of learn as we go. So you can give it within 14 days of exposure. It's indicated for those who have had that high risk exposure, but have not received a smallpox vaccine within the last 3 years. The CDC, it is a 2-shot series. The CDC on a webinar said that if someone has been previously vaccinated, so if you have someone who's 60 years old and they got their smallpox vaccine back in the day, the CDC said they would still get 2 shots. The state, they said they would only get 1 shot. So I think that's still to be determined. I think that's something we can deal with later when and if it comes up. Main thing is to kind of like with Hep A, we just want to at least get them 1 dose. So for Jynneos, it is indicated for people with certain occupational risk factors. People working in healthcare right now are not considered high risk and would not be considered for pre-exposure prophylaxis. It's more for people working with like laboratory animals and things. But it is also indicated for the high risk post-exposure prophylaxis. It is approved for those 18 and above, but if you do have children, you can get an expanded access investigational new drug application approved through the CDC. It's just some paperwork. 2-dose series, at least 4 weeks apart. If you have people that like have ongoing risks, there are boosters involved. It is subcutaneous. Again, contraindications are just allergies to the components, which I listed here. They also do discuss that people with serious cardiac risk factors, you may want to counsel them about a theoretical risk of myocarditis. There has never been a case of myocarditis with Jynneos. It's just there has been with ACAM 2000, and it is not known what about that vaccine causes myocarditis. So theoretically, since this is a smallpox vaccine as well, that could be a risk too. So if we ever did need post-exposure prophylaxis, if we had a case, we would contact MDHHS, they would contact CDC's EOC. They would say, yep, you need vaccine, how much do you need? The order would be placed, we would get it within a day or 2. They only are sending vaccine, they are not sending all the supplies like they did with COVID, just as an FYI. The VIS form is available on the state website where all the other VIS forms are. I just put this here. There is medication and immunoglobulin available. So if you have clinicians that feel like they need it, that can be discussed as well. And some of it is available through the Strategic National Stockpile. The main care is supportive. One thing of note, a risk can be people touching the lesions and then touching their eyes and infecting their eyes, which can lead to blindness. So counseling patients to not touch their eyes is an important aspect. And if they start noticing any issues with their eyes, to start working with their doctor and ophthalmologist right away. This is just a list of the treatment, just so you have it. And that is it. I know that was a lot, and I apologize, but I can take any questions if you guys have them.
Dr. Morse, this is Curtis McCost. I have a quick question. For the contacts of folks, I suppose depending on risk factors, but is there any talk about quarantining those individuals? Yes,
so I may have just buzzed through it way too fast, but yes, you want to, when it says monitoring, you're going to quarantine. Yeah. So my assumption is those ones that you're monitoring, you're also going to be quarantining them. But I guess it might be based more on risk stratification. So I guess if it comes to if there are people that just have a really low risk exposure, we may not have to quarantine all those people. But yeah, I guess my assumption was anyone with one of those exposures that needs to be monitored would also be quarantined for 21 days.
Perfect. Thank you for the clarification.
Rosie had to step in with the patient, but she was curious if monkeypox is something.
Hold on, sorry, I can't hear you.
Oh, I'm sorry. Can you hear me?
Yeah, go ahead.
Okay. Rosie had to step in with a patient, but she was curious if testing for monkeypox was going to be something that they test for during medical clinics?
Only if you have a strong clinical suspicion. So it's not going to be screening whatsoever. If there was a rash that was concerning and there was a concerning history, and there was no other diagnosis that seemed more likely. If there was a concern of monkeypox, then certainly they can test for it and it can be sent to the state lab.
Okay, thank you.
Uh-huh. And I forgot to mention, I meant to put it in there, but obviously there's a lot of concern that there may be stigmatization with this illness. And so there's been some discussion about referring to it as MPX rather than monkeypox. And also, just making sure that it's not a disease that's only targeting one specific type of person. There's just certain risks that it is targeting, and we just need to work on those risks, not those individuals. And so the CDC actually has done a really good job creating educational materials. If you need them or want them, those are out there. But again, as you can all imagine, there's a lot of concern about the stigma that may be coming with this.
Great. Are any more questions? Last call for questions for Dr. Morris. If not, we do thank you, Dr. Morris, for pulling that together and sharing that wealth of information and kind of keeping us all abreast on the latest and greatest. And she will share those slides, and the link to this recording will be available to rewatch, and also the slides. So we will have those as a resource and a reference.
And the communicable disease nurses do have materials for testing. So if any of the family planning or STD staff do have concerns, those should be available. And if any of the CD nurses think I'm lying, if there's a concern about that, you can talk with each other. But that's why I'm really glad that family planning and CD are on this call, because I want to make sure that everybody does have materials available and knows where to get them. So you might want to just talk with each other and make sure, to Rosie's question, just make sure they know if they do have a case or